Hello and welcome to another Pipe of Pearl. Today's Pearl, we're going to attempt to tackle skin disorder consultation. Now this is probably one of the largest and most diverse consultations any person who works in primary healthcare can come across. The disorders range from the incredibly benign, as in a bit of dry skin, slight irritation, all the way up to skin disorders that are actually classified as a medical emergency. So if anyone ever says you can't have a dermatological emergency other than anaphylaxis that involves all organs, then hopefully by the end of this presentation you'll have a few more disorders in your arsenal and things to look out for. The complexity and diversity of skin disorders is immense. So what we're going to focus on today is a general consultation in order to narrow down the field of classifications of skin disorders, as opposed to looking at each skin disorders in great detail. In the future, I'll do individual presentations on common disorders, so then you'll have a better idea. But this lesson is all about the holistic consultation of a skin disorder. So moving right into it, the skin is obviously the largest organ and it involves the most diverse presentation. The thing that you need to really understand is there's no such thing as an actual skin disease. Okay, but there's many diseases and pathological states that affect the skin. Okay, so unlike other organs where you can actually have a disorder that is all about that particular organ, a lot of the time when we're dealing with the skin, it is something else happening in the body that has a manifestation that you can see on the skin. And this obviously leads to a strong psychological complication. The skin is often said to be the soul's mirror, which denotes that it's what everybody sees. So it's basically what you project into the world. So any form of disfigurement, like burns, can have psychological complications, which just adds to the complexity of skin consultations. Now, there's not a GP or a primary healthcare worker out there that hasn't had somebody come in with either a direct skin complaint or a disorder that involves some sort of skin component. Despite its commonality, it is probably one of the poorest trained areas in consultation, and it is often overlooked or skipped or underdiagnosed or trained as a result of its complexity. Now, this leads to a huge amount of referrals or dismissals of anybody that has a skin disorder. What makes it quite confusing is the excessively long list of terminologies, which really complicates things and unfortunately does sometimes make it easier to get a diagnosis using the correct terminology, but the differences are so subtle in real life that they are often misused when dealing with terminology. And some of these terminologies directly translate to thousands, literal thousands of disorders. So if I haven't scared you away and you haven't turned off the presentation, then I applaud your commitment, because at the end of the day, a good consultation and a lot of the times good collaboration with very good subjective data and objective findings can go a long way in getting the right diagnosis and actually aiding in this person's care. So having a look at terminology, whenever you're working in a primary healthcare setting, it is best to always have a chart with these terminologies on it. Now, for those that have access to the Moodle that you'll find this video, there will be a chart on there that has these things that you can refer to, save to your phone in order to aid in your terminology. Because the easiest way to look at the terminology is you've got primary and secondary lesions. Now, whilst they sound simple in their definitions, a primary lesion is denoted as a lesion or abnormal skin condition that may be present at birth or acquired later, whereas a secondary lesion is as a result of irritation or manipulation of quite often a primary lesion. Okay, so if that's not confusing enough, the easiest way that I use primary versus secondary lesions is primary has grown from within the skin structure or is manifesting on top of the skin, whereas a secondary lesion is a result of some sort of irritation or often overgrowth of those particular skin cells. Okay, so breaking down primary versus secondary lesions just a little bit further. I won't go through every one because it's nauseating. But if you class macule and patch together, the difference is the size of it. So that's when you have a flat lesion that is either less than a centimetre or greater than a centimetre. So if you have a small macule, that basically just small flat lesions, as opposed to an area of skin that is known as a patch. This is the similar distinction between a papule and a plaque, which is a raised lesion less than a centimetre or over a centimetre. Then you move into your blisters or blistering types, where you have a pustule filled with pus, a vesicle or a bulla, which is again denoted by size, and then you have your growths, whether it's a nodule, a tumour, or a cyst. From there, they get kind of obvious because it just looks like a wheal or a blood spot. Okay, so they're the primary terminologies that you can use, but there are a lot more that you can go into. Okay, so if you don't remember all of them, that's fine, but if you try to use the direct descriptions, and if you can't remember them, just use things like measurements. Okay, they have a flat lesion that is 1 centimetre, things like that, then it will go a long way in your documentation. Secondary lesions are things like your scars, your erosions, your ulcers, your fistulas, stuff like that. Okay, so a little bit easier to see and a little bit easier to pin down. Terminology is only used to help describe the lesion that you are looking at. So because we have modern technology now, the use of cameras and pictures are a fantastic tool. And if you're ever doing a handover with somebody over the phone, it is a great idea to take a picture and send it to them first so then they can see it. A lot of the times, as you get more experience in the primary healthcare space, diagnosis or at least lumping of disorders is a lot easier if you can physically see the actual skin lesions themselves. So moving to that, the goal in aiding in all this confusion and all this overlapping terminology is to try to figure out what sort of category this skin disorder fits into, as opposed to pinpointing right down what the actual disorder is. Remembering there are literal thousands. So there are 7 main categories that have been defined, and these categories have been defined by a Professor Robin Marks, if you're interested, and he's quite a well-known professor in the dermatological realms, and he has denoted 7 categories in which skin disorders fit into for ease. And if it doesn't fit into these 7 categories, then referral to a specialist is recommended, because it is either something very unique or a unique presentation of one of these disorders that you're looking at. So the 7 categories are infection, acne, psoriasis, dermatitis, which is also known as eczema, urticarial rash, sun-related skin cancers, and drug-related eruptions. So as we go through this presentation, we will delve down a little bit further into these 7 categories, especially once we get to the assessment aspect. But the whole point of the subjective questioning and objective investigation is to try and find out where it fits within these categories itself. So moving on to our actual subjective investigations. We use the same sort of acronym. If you don't like using EPSAN, then that's fine, find your own one. But the questions are what is important. So when we're dealing with the event, we're going to know where the lesion is and how long they've had it. Now, I could go through a huge list of probable diagnostic areas based on where you find a rash, but I encourage you to look up maps like that, because the list is many and there's a lot of overlap. But as you develop your clinical exposure, you'll start to learn that a lot of particular lesions and skin disorders are dedicated more often to certain areas. Okay, so just keep that in mind. That's why the location is very important. But how long they've had it often denotes how much of an irritation it is. Unless you've walked up to someone and asked them directly, do they have any complaints, and then they've openly admitted to a skin disorder and they've actually come to see you, then it's usually broken down into 3 categories of time, which is acute, subacute, and chronic. So acute, you're dealing with at hours and days. Now, most of the time, you're looking at your urticaria, your infections, or your drug-related disorders and allergies when you're dealing with that sort of time frame. When you move into the subacute, we're looking at the days to weeks marks, and that is more of your bacterial infections over viral, and it can also be more of your fungal-based infections as well. Just to fit it in, you also start to find a bunch of your psoriasis type disorders in that subacute realm. Once you move into the chronic side, then we're pretty much done with most of the viruses, most of the bacteria, and we're looking at our dermatitis, psoriasis, and then we start moving into our skin cancers and warts, that sort of thing. Okay, so having an idea of how long they've had this problem for can really help class where they're sitting. Now, obviously, it's not an absolute. Okay, you can have a fungal infection that can go on for many, many weeks if left untreated. Okay, so that's when we move into past history and we ask about how the lesion has changed or grown. Because if the lesion evolves and stays in the same area, but it starts to spread, it's more likely fungal related as opposed to a inflammatory disorder that you can have it popping up in different areas of weakness. It's always good to ask the person if they've had it before, because some people are more susceptible to certain disorders, and that is particularly the case when we're dealing with our psoriasis themselves. Social is a very important thing because that denotes whether or not we're dealing with an infectious lesion or rash, or whether it is unique to that individual. Okay, it's obviously just helps break down those infectious states like your impetigo. We want to know about their work, their hobbies, any new activities, any new products, any new clothes, any new cleaning products they've used, because that leads us towards dermatitis. And in particular, contact dermatitis is very common when you're dealing with irritants. When someone's working in the field and they're particularly filthy and they're doing a huge amount of physical work, then you open up for hygiene-based lesions, which is inflammatory and or fungal-based lesions that you can have growing. And that is hand in hand with hot, humid environments. You have an increase in inflammatory-based disorders based on fluid and moisture intake of the skin, and also the perfect environment for fungus to grow. When you're in a cold environment, what you tend to find is very dry skin, and sometimes this dry skin can get inflamed because the person is scratching it at night and not realizing it. So just keep that in mind, that it's not just the hot environments that we get our lesions, it can also be the very cold. We always want to know about the person's current health state, so we want to know about their medical history. Diabetes is a classic one for having some pretty damn impressive fungal growths, quite frankly, because they love the sugar. Okay, so if somebody has diabetes, fungus, especially oral candida, things like that, are far more common, but also anyone with a weakened immune system can have manifestations of certain viruses and are more prone to certain infectious-based lesions. Family history is a very important thing to ask when you're dealing with psoriasis and when you're dealing with your sun-related lesions as well. Moving on to your subjective questioning, we can ask about the characteristics of the particular rash or the lesion itself. Okay, so pruritus, someone complaining of an itchy rash, is very common. But what we want to know is we want to know how bad that itchiness is. So when we pinpoint down how bad a itch is, it can really help diagnose compared to an eruption as opposed to something that's not that itchy. So if somebody says that it's very itchy, and that usually means that they're waking up at night with the actual disorder, it tends to be in line with the acute, and you're dealing with either an infestation, insect bites, or urticaria itself. Someone says that it's annoying, you can definitely feel the itchiness all the time. Then we start moving into more of those psoriasis, more of those tinea-based ones. And if it's not often, you just know that it's itchy, but it's more of an irritant, then it's more of your impetigo, ulcerative type things, as opposed to your acute eruptions of insect bites or urticaria. Okay, so denoting how bad it is helps us in our management of the actual casualty, but also can help fine tune what sort of disorders we could be talking about as opposed to not. When we're dealing with allergies are very important in general for medications, but there is a strong link with your urticarial rashes and things like hay fever and in particular asthma. So if somebody has an already high susceptibility to eosinophilic reactions like hay fever and asthma, then they are more likely to get these urticarial histamine-based skin lesions than people that aren't. When we ask what medications they're on, it's not just because we want to talk about interaction. There is quite a large list of drugs that we'll go into that can cause those drug-related eruptions. And some of these can be life-threatening. So we have our TENS, we have our DRESS, and we have our erythroderma. Now, each one of these rashes we'll go through, and I'll give examples on so that you know what it looks like and what drugs are more susceptible for them. But typically, if we look at our sulfur-based drugs, our antibiotics, and our NSAID, they're the largest classes of drugs that causes our medication or drug-related eruptions. Okay, so that ends the questioning side of the house. When we move in to our objective, we need to start thinking about what tools we can use in order to aid us in our diagnosis of disorders. So things like magnifying glasses are fantastic. You absolutely need a good light source. That's a no-brainer. If you have access to ultraviolet light, if you have access to a dermatoscope, they can be all very, very, very useful items in aiding in diagnosis. But in reality, we're probably not going to carry these things around in our packs, and we're only really going to likely have them in clinics. So when you're all by yourself in the middle of nowhere, you can use your modern mobile phone, because you obviously need that on you in order to make phone calls. So that can be used for a light source, can be used as a camera to zoom in on things in order to get a better look at the actual lesions themselves. And you can obviously also take pictures to share them with anyone that you're handing over to aid in their assistance and their actual diagnosis as well. So don't be afraid to use the technology you have, and you can even start looking into apps. There's a whole bunch of apps out there that help you map moles and those sorts of things. But realistically, if you end up finding one, you can also find a database of skin lesions that can help with your terminology. So once we have our tools, we'll move into our objective investigation. And when we're in the field, it is really all about inspection. It's all about looking at the actual lesions or rash itself. Now, it is very common for people to forget that this is not a skin disease. This is a manifestation of something else that's presenting on the skin, and therefore forget the rest of the body. Okay, so don't forget your general objective investigations that you'll need to do, things like vital signs, because if there's a skin irritation with a fever, then that increases the need to evacuate the person. Okay, you're dealing with something quite sinister, and you need to evacuate them and sometimes aggressively treat them as well. But we can also look at things like lymphadenopathy, organ function, overall allergic-based symptoms, especially if you're dealing with an urticaria rash. So don't forget the rest of the body just because you're dealing with a skin disorder. Once the rest of the body is sorted, we can start looking at the rash itself. So you absolutely need a good light source, and we need to look for characteristics. We need to know how deep the actual lesion is. Is it just the epidermal, or is it the dermal? Now, when you're dealing with the epidermis itself, you're never going to get a lesion that only affects the epidermis. Everything that affects the epidermis is going to affect the dermis in some degree. Now, I know it sounds weird and it sounds like that I've got them mixed up, but it's not the case. If you have a dermis-based lesion, then you can have something just growing in the dermis that is just putting pressure on the epidermis, but doesn't actually involve the cellular structures of the epidermis. Whereas the epidermis can be affected with scaling, crusting, even weeping, and its lower layers, the cellular structure of the dermis, are also affected because they're the base. Whereas if you have a abscess or a lesion growing in the dermal region, it doesn't actually affect the cellular structure of the epidermis. So always have a look at the actual lesion, have a palpate, see what it actually feels like, looking for things like size, movement, and actual texture of the lesion, and denoting its color. From there, you can also look at its spread across the body. Look for certain characteristics of patterns like fixed lines versus more of a diffusion of a rash. You can also look how distributive it is. So always look for your dermatome link, especially when you're thinking herpes zoster. So your varicella virus that causes shingles is absolutely classic for your dermatome. And you want to know whether or not it is widespread, central, or in the peripheries. That's your definitions when you're dealing with distribution. Whilst certain regions of the bodies are more susceptible to certain types of skin lesions, you don't want to fall in the trap that everything associated with the feet is tinea. Okay, so just remember the age-old adage that is all elephants are grey, but not all grey things are elephants. And it should help you not fall down the trap of thinking that just because it's in a region, it must be the most common thing that occurs within that region, and continue your investigation. Quite often, and it may sound weird for people that haven't seen much of these before, but there is often a toss-up between an inflammatory-based disorder and a fungal-based disorder. And sometimes there's this type of psoriasis that can also get mixed into looking like a fungus. And there's also a very rare type of dermatitis that also looks like a fungus. So a lot of the other non-fungal disorders, when you're dealing with dermatitis and your psoriasis, involve some sort of inflammation. Now, whilst you have local inflammation associated with the fungus, it's not as systemic as the other disorders. So you can do an inflammatory test. Now, what this does is basically tests how sensitive the patient's body is to minor stimulus to overreact with inflammation. If you have an inflammatory based rash, you're going to have a whole bunch of inflammatory mediators and signals floating around the body. So this test is simply grabbing the back of your fingernail and drawing a line on a part of the patient's body. This can be the arm, this can be the leg or the back. It doesn't really matter where it is, but you just draw a line down the back, not too much pressure, just run your finger down it basically, and that will cause microcellular trauma that will release inflammatory mediators and cytokines. And most of the time, if you do that with a healthy body, nothing will happen. If you do it with someone who is pro-inflammatory, so has a huge amount of inflammatory mediators, then you'll actually get a reaction, and you'll be able to see the picture that is drawn on them. Now, you do need to ask the person whether or not they're susceptible, because there are people out there that are just highly susceptible, and it is often linked to the color of the hair. So redheads are more susceptible to inflammatory stimulus than non-redheads. So play it by ear. It's obviously not a definitive test, but it can help in understanding what sort of state the patient is in. If you get back to a clinic and you really want to tell the difference, then we do things like a Woods test where we look at it under ultraviolet light in order to see the patterns of the actual rash. And you'll have green or yellow lights as opposed to your pinky colors if it's pityriasis, vesicolor or something like that. Okay, so that can help. And you can also do skin scrapes. Skin scrapes are fantastic, looking at those under a microscope, and that will tell you straight away whether or not it is a fungal based disorder as opposed to an inflammatory. But if you're in the field and you need to make a decision based on medication that you want to give, then this test can help. Always tell the patient that you could be wrong. And if you're wrong, therefore if the actually gets worse, then get them to come back. And we'll discuss more about that when we deal with our treatment management. But let's just have a look at the different classifications that we can get when we're dealing with our assessment. So the first thing we mentioned was infectious. That was one of the first lumping categories that we had. And obviously infectious can be broken down into bacterial, viral, fungal, and also your protozoa. So things like scabies, that sort of thing, can also be an infectious, even though it's more of an infestation. Okay, so please forgive me for that one. Okay, so when we're dealing with bacterial, the most common bacterial problems you'll have are things involving hair follicles. So folliculitis, your furnicles, carbuncles, and abscess are all basically the same pathology that are in varying degrees of complications or enlargement based on what's growing underneath in an abscess. Now, each one of these can turn to cellulitis, so you need to act and treat, and realistically the treatment for them is the same. So cellulitis is quite easy to find. Okay, it's a large diffused area that is often weeping, and you'll feel very, very tight within the regions. Now that's something that needs immediate treatment and often evacuation and antibiotics. Impetigo is one of those ones that's quite characteristic when it looks like it does in the picture, which is on a child, but you can get impetigo on any region, basically. It just needs an area of weakness. The bacteria will move in and then it will spread around the body from there. Now, erysipelas is a very special type of cellulitis. It's actually more dangerous than cellulitis and has its own treatment regime associated with it. I won't go into the specifics between them now, but I will cover it in a separate lesson to come, because it's one that you've got to look out for. And what it involves a cellulitis of the epithelial layers themselves. So a huge amount of increased pressure. You have a bright red color, and as I mentioned, it can actually be more dangerous than cellulitis. Bottom line is a bacterial infection can need antibiotics, but don't always need antibiotics, especially when you're dealing with things like folliculitis. Once we move away from bacteria and we move into our fungus, most common type of fungus that affects the body is our tinea, and it has different names associated with different regions of the body. If you can't remember those regions and don't remember those names, then that's actually okay. It doesn't really matter. You can say tinea of the groin, tinea of the foot. Okay, people might get a little bit precious about it, but they'll know what you mean. Okay? It often has very distinct borders and sometimes some incredibly pretty patterns. At other times, it can just be a diffused red inflammatory looking rash that has a mixture of fungus within it. Hence the confusion between fungus versus inflammation. Okay, so when you're dealing with tinea cutis, for example, in a hot environment, you're going to have associated inflammation with the fungal infection. So it's hard to know. Most of the time it's denoted as tinea based on the environment and treated as such, which is not bad. Okay, but if it doesn't go away, then it's more likely that it was an inflammatory based disorder and you just need to use a different cream. When we move away from our tinnias, our pityrosporums are quite rare, luckily, and they only usually affect those that are immunocompromised. Now you can get pityriasis versicolor, you can also get tinea versicolor, and it basically just means that it is a widespread fungal infection. Candida is excessively common around the mouth and the genitals, but can affect the same regions that tinea can. It's good to know the characteristics between tinea versus candida, because there's certain creams that work better on the different species. So candida will often come with white tops as opposed to your characteristic red. It also has less defined regions than your tinea as well. If you don't quite get it right, then treating it as tinea often has better results than using the Candida-based medication on the tinea species. Viral are quite nasty looking rashes, but luckily quite unique as well. So herpes zoster, or shingles, or varicella, has a number of wonderful names. Can present itself as chicken's pox, often in a junior age, which is small spots, very, very itchy, all over the body. Okay. When it moves in for a second time round, quite often, or mostly in adults, it takes the form of shingles, and you end up with this large diffused rash that is non-blanching that follows the dermatomes themselves. Okay, so it can get pre-eruption, which is generally your itchiness and burning sensation. Once it's erupted like this, it is highly contagious and can be quite a medical emergency. So it's always a good idea to check the dermatomes, look for these non-blanching rashes, and if you find them, they need evacuation, they need isolation, and they quite often need care. Warts are simple, okay, caused by the human papillomavirus. Yes, it is still a lesion that is caused by a virus. Now, your molluscum contagiosum are quite a unique looking lesion, and they look like little bacterial pustules. But the idea of them is they're small raised areas that often have a dead center. They don't have to have a dead center, but this is what you will often find, and they're spread little pustules around the body. Okay, and that's caused by a virus as opposed to a bacteria. Now from there you can also get your scabies and your mites, which I won't go into today, but that is another type of skin lesions that you can find that is caused by an infection. Moving on, and with the first overlap, we have acne. Now acne can get made a lot worse when mixed with bacteria. Okay, so it's often a type of bacteria that is mixed in there before we get our pustules and our cystic lesions, but it starts with pores being blocked, plugged. And it's often associated with your androgenic hormones. So either females with PCOS or high androgen levels, or puberty-based males that obviously have those high levels of testosterone. Now, obviously, if you have individuals that are taking testosterone supplements, then it can be more susceptible as well. But as you can see in the picture, there is a huge array of different types of acne, and depending on how bad it is, will generally denote what sort of treatment they need. Now, people that will go through the habit of picking and lancing and squeezing and scratching and all sorts of things like that are often more associated with having scarring as a result of acne than those that don't. As hard as it is, they're often encouraged not to lance themselves and go see someone who can do it properly in an environment. The treatments for acne vary from normal face washes right through to antibiotics themselves. Okay, psoriasis is a unique one and is actually caused by an increase of cellular growth. You often get this flaky raised area, but those raised area can have manifestation of inflammatory based properties. So just because it's caused by an increase in cellular growth doesn't mean the cellular growth doesn't involve lower cellular damage, which can actually be quite a self-feeding cycle as well, which causes your inflammation. So it can be white or it can be red. Okay, so it can be quite difficult to pinpoint if you don't know what you're looking for. So look for those scaly areas or those diffuse type rashes that have the underlying flakiness associated with them, and that is more likely your psoriasis. Quite often diagnosed with a skin scrape to denote it against that fungal infections or different types of dermatitis. Moving on to dermatitis, again, we have a huge array of those. The most common type of dermatitis you'll get is your atopic dermatitis, which is a special form of eczema, which usually starts in childhood, and people are just more susceptible to it. It is the dry, scaly, red skin that you'll find. Contact dermatitis is the second most common, and that's associated with people that are associated with irritants. So this is where you'll find the most common occurrence with people that are exposed to a new environment, exposed to a new chemical, or not that used to poor hygiene will get versions of contact dermatitis. Now, this contact dermatitis is often linked to hand dermatitis, which just means that your hands have been exposed to something and causing this inflammatory response of your skin. And from there, you can get special types of dermatitis, ones that are associated with veins leaking, therefore creating a thickened plasma layer over the top of the skin that looks quite scaly. That's your stasis dermatitis. And your nummular eczema is the one that is most commonly misdiagnosed as your urticarial rash or your fungal infections as well. Okay, because it does cause those round shapes on the skin that look like your hives or can look like your isolated fungal growths also. So if it wasn't hard enough, we also have a form of dermatitis that can get mixed in as well. Now, dermatitis is classically caused by inflammatory-based mediators, but inflammatory-based mediators also activate allergy-based mediators, which is the primary cause of our urticarial rashes. So urticaria and dermatitis, quite common. Contact dermatitis versus urticaria is an ongoing debate, but the big difference is often how rapidly it occurs. If it occurs rapidly, then we're dealing with your urticaria. And it's often associated with other problems like weeping eyes, runny nose, other signs of an allergic-based reaction. Contact dermatitis can still be an allergen-based response, but it's more of an allergen, meaning an irritant. So it often takes 24 to 72 hours to kick in. Not that the patient will actually be aware of that, but it also stays longer and only affects the skin. So you won't have those extra symptoms associated with it. Urticaria can be associated with anaphylaxis. So obviously, you need to look out for that because it is a medical emergency, but it can also just be skin mostly. Okay, so no other effects on other organs, therefore doesn't fit into the anaphylaxis and definitely not anaphylactic shock. So it is a systemic, widespread allergen-based lesions. When we move into sun-related disorders, this is where things will often need our referrals. So the different types of skin cancers that you can get is your actinic keratinosis, and this is almost like a little warning sign. Okay, it's a precursor for cancerous growths, and you get this scaly, crusty, often yellow skin that most commonly occurs on the scalp of balding men, but it also occur on the tip of the nose, the ears, and the back of the hands. When you go through atypical moles, they are things that really look like melanoma, but on professional investigation, they're not. Okay, Merkel cell carcinoma, very rare, okay, but looks almost like a blood blister with a dead spot attached to it, and they're quite dangerous. Okay, they have a huge risk of reoccurrence and metastases as well. Melanoma is obviously the most dangerous one, and that is what the acronym ABCDE is used to find when you're dealing with an assessment, is signs of potential melanoma. And then we move into our squamous cell and our basal cell carcinomas. And these are quite common skin lesions that occur. Basal cells occur more commonly than squamous cells, but they can occur on any parts of the body, and it's obviously linked to the exposure of the sun. If you don't treat a squamous cell carcinoma, then it can metastasize and be deadly, whereas a basal cell carcinoma is one that doesn't spread often. I'm not going to say ever, but it's not known to spread, so it's often just removed and then it doesn't actually reoccur. When you're looking at moles, now obviously you can refer the people on to have a good investigation with dermatologist or a GP that's trained, but the general rule of thumb that we're looking for when we're dealing with moles is the absence of asymmetry, the absence of a border, as you can see in the pictures, a multicolored mole, a large mole that's greater than 6 mil, and realistically, even though you won't tell, the patient will have to tell you, is one that has evolved from a single into multiple spots. So it has that evidence of metastasis in the local region itself. So that's the ABCD criteria that we use to denote a mole, which is just an increase of melanin production on the skin versus a potential melanoma. Okay, and the last area we'll look at is our drug-related ones. Now, these ones are often linked to a medical emergency, so hence why we've broken them up into each picture. So drug-related rashes are typically symmetrical, meaning they appear all over on both sides of the body, and they don't tend to cause any other symptoms. Some of these rashes may have accompanying itchiness and tenderness. If the development of the RAP started on a new drug, you really need to be suspicious. So if someone's just started the drug and then they come in with a rash, then you need to be suspicious. Now, unfortunately, this can happen within hours, but can take several weeks to actually occur as well. So the first one, Exthane mantis rashes, they're considered the most common type of drug rashes and account for 90% of the cases, which is good because they're not that sinister. Okay, it's a small, raised, flat lesion and reddening of the skin. Now, these are most commonly caused by your penicillins, sulfur drugs, cephalosporins, and the anti-seizure medication. The photosensitivity reaction is obviously worsened by sun exposure. So certain types of drugs make people extra sensitive to ultraviolet light, causing itchy sunburn when they're outside, even if they're wearing sunscreen or protective clothing. Now, the most classic one for that is obviously our tetracycline antibiotics, but it can also be certain antifungals, antihistamines, and statins as well. Now, when you start seeing these two are when things are complicated and things need to start getting treated as medical emergency. So erythroderma is a potentially life-threatening condition that covers nearly all of your skin, becomes itchy and red. Your skin starts to grow scaly within 7 days, and they also can be associated with a fever and physically hot to touch. It's almost like a rapid effusion of blood into the outer skin, causes increased growth and heat as well. Now, these drugs can be sulfur-based drugs, can be penicillins, and your chloroquines as well. Okay, so just look out for those because certain underlying health conditions can make it worse, such as somebody who suffers from atopic dermatitis or psoriasis can actually make this erythroderma more likely. And when we move into toxic epidermal necrosis, that generally involves about 30% of the person's skins, and it's denoted by large painful blisters, as you can see, and it can also lead to large areas of the skin actually coming off, leaving raw open sores. Okay, so it's a very violent, sinister reaction. Again, we use sulfur drugs, but this one can also come from certain NSAIDs. Now, it's very close to another disorder known as Stevens-Johnson syndrome. That's just not as widespread, but is caused by the same sort of reactions. And the last one is your DRESS. Now, your DRESS stands for your drug reaction to eosinophilia and systemic symptoms. Now, this is a rare type of drug rash that can be life-threatening and can notice after 2 to 6 weeks after starting the new drug. Now, this one is red, often over the face, and additional symptoms include your fever, your swollen lymph nodes, facial swelling, flu-like symptoms, and organ damage. Okay, that's why it's important when you see these rashes to do those systemic investigations and not just look at the skin. Now, possible drugs that cause DRESS are much of your same, except you've got anticonvulsives and you've also got proton pump inhibitors as well. Now, each one of these in this particular slide is a medical emergency and needs immediate medical attention. So once you have a general idea of what you're dealing with, you've got to go through the treatment regime. As always, you treat emergencies first. No brainer. You have anaphylaxis, you have TENS, you have DRESS, you have an emergency, you treat the emergency. From there, if you're not dealing in the emergent space, then you can move on to the rest of the treatment. So as far as education goes, you can obviously teach the patient all sorts of things depending on where they are. Things associated with hygiene in the field, keeping themselves clean, keeping themselves dry, all this sort of stuff, especially feet care. The education can go on and on. General rule of thumb is if someone's got a drying disorder, then you use non-drying soaps. And a lot of the times if someone's got dry skin, it's best to teach them, as weird as it sounds, to only use soap on their groin, their armpits and their feet. And the rest of the skin, just use water. Okay, as strange as that may be for some people, that's actually the recommendation. If you have lesions, especially things that look like acne, avoid popping, scratching, self-debridement. Just avoid that as much as you can because it's more likely to cause scar, and then you'll have rashes associated with fibrosis, which tend to be more sinister in nature and also less appealing psychologically as well. When you're dealing with treatments, you need to pick what you're dealing with, okay, and then that denotes the type of substance that you will use. So creams and lotions are generally used for acute rashes, whereas your ointments are used for scaly rashes because they have better penetrating and better staying power as well. When you're trying to figure out how much cream to give somebody, then we can actually move back to our rule of nines that we use for burns, and we can use that to denote how much cream we're going to use. So as a rule, the rule of nines, 9% of the body, so 9% of the skin, will generally take 3 grams of cream each time. So if someone's on cream twice a day, then they're going to use 6 grams every day. So you look at how big the actual tube is, and you'll give them enough cream to effectively treat the area for the duration. Okay, now, a person can use natural creams. There's nothing wrong with it. It's obviously best not to mix with the medication, but natural creams like aloe vera, it's very good. It has antiseptic, anesthetic, anti-inflammatory, antipyretic, and moisturizing properties. So it's very useful for a huge array of different skin disorders. Every female's favorite pawpaw cream. I have no idea. I've never seen it advertised, but everyone seems to have it. It's pretty amazing. It's very good moisturizer and very good antipyretic as well. Tea tree oil obviously has a mild antibacterial and antifungal properties. It can be used. Some people like using honey, and if they do, knock themselves out. Okay, it's a non-antibiotic and protective layer. So if someone has any inflammatory or bacterial disorder, honey can be used in order to aid in the care. Okay, obviously not treat it, but sometimes the use of these long term can be more beneficial than people give it credit for. But moving more on to pharmacological choices that we have, it all depends on what you're dealing with. So if you're dealing with impetigo or boils that are greater than 5 centimeters or cellulitis, then it's treated with flucloxacillin. That's a tablet. Okay. If you're dealing with localized impetigo, then you can go to mupirocin, which is also known as Bactroban, can be used for those localized impetigos. If it's widespread, flucloxacillin is your choice. Someone has shingles or genital herpes, then your valcyclovir tablets can be used. But if someone has localized herpes simplex, then acyclovir cream can be a good choice. When we're dealing with wart, we can use our wart paints, that sort of thing, but often we'll need cryotherapy to treat that. Tinea, we use terbinafid. Terbinafid is more useful than micronazole when you're dealing with tinea species. When you're dealing with candida species, it's more susceptible to micronazole. If you don't know which one it is, meaning candida has caused tinea type problems, then you treat as per tinea. You use your terbinafid. But if it's oral candida and it's quite obvious, then your micronazole can be used. Now, when we're dealing with inflammatory-based problems, then we can use inflammatory-based creams with permission. Okay, so we call up, we get permission to use them because there's a whole array out there that change from 0.5%, 1%, sometimes greater of these corticosteroid creams. Now, depending where they're going to be put and how much you're going to use, will usually determine what sort of strength you're dealing with. So the 1% is good for rashes in small areas. If you need to cover a larger area, then it's best to get the 0.5% hydrocortisones based or corticosteroid based cream. So just keep that in mind and have a discussion with someone before prescribing it over, because long term, which some of these are, long term use, can cause problems. So we're never actually going to give these things out for people with psoriasis. Okay, we're going to only really use it for those local contact dermatitis type problems in the short term. Now, the big question between our corticosteroids and our antifungals, if you don't know the difference, is if someone has a fungal infection and you give them a corticosteroid, you're going to make the fungal infection worse. Now, this should never be used as a diagnostic tool, even though it has been done in the past. It just shouldn't be. It is a diagnostic indicator that if you put a corticosteroid cream on something and it gets worse, then that corticosteroid cream is to stop and you're to start antifungal creams over the top. Now, if you put an antifungal cream on an inflammatory problem, then sometimes the inflammatory problem can get better because it doesn't have the associated fungus moving into it. It can just take a little bit longer and doesn't do much for the itchiness and irritation. Now, other supportive creams that we have out there are obviously our anti-itch, which is our Urax, and chamomile lotion, which can be used pretty liberally. But just remember that if you're using any of these anti-itches, that they don't use them with the actual treatment cream, because the skin only has so much capacity to absorb cream, and most of it just gets washed off, especially in the field. Moving away from our pharmaceuticals, we're going to start looking at our restrictions. So restrictions can be based on psychological means. So if someone has a particularly nasty skin lesions, they have a psychological reason to be isolated whilst they continue their care. It can be a consideration, as to is risk of secondary infection. Impetigo is a classic one. Shingles is another one. You can also move them along for comfort. If someone's got particularly nasty lesions that they can't wear shoes, or they can't be in the field, or it's difficulty walking, difficulty doing whatever they do, then we can give them restrictions. PT restrictions is often associated with hygiene and the ability to do it, as to is working in certain environments. So just talk to the patient, find out what they do, what they can do, and give them supportive restrictions. Referral, realistically, you can refer anyone you want, but as a general rule, if you find something that you can't lump into one of those 7 categories, then they probably sit outside that category, or they're an atypical presentation that needs a specialist. If you're unsure, you can refer them. There's nothing wrong with that. That's why we have dermatologists, because lots of people are unsure associated with skin disorders. If someone presents systemically unwell, take that into account, and it could be more sinister than a simple dermatological infection. So referral on to further treatment is a good option. And if anyone ever tells you that dermatological emergencies don't exist, just refer them to our drug-related eruptions that can happen even to our demographic, and the management for such needs to be taken seriously. Okay, so that brings us to the end of our skin consultation. It's quite a long one, but as you can appreciate, there is a lot to go through, and there's also going to be a lot of individual lessons denoting the pathology of most of these disorders. Okay, so bottom line for skin consultation is it's going to be difficult. You're probably going to get it wrong first time round, but at least you're going to be in a position that you're going to pick up the red flags. You're going to more likely categorize it as one of the 7 disorders, and you're going to either treat or refer the person for the correct management. But until next time, take care.